welcome to the last area of study, mental health, and most likely our second last video for the year. Time's getting on, so let's get into this one. And always it doesn't start properly. Okay, mental health. So you definitely need to know a definition of mental health, and some of the health and human students will already know this definition. So a state of emotional and social well-being in which an individual realises their own abilities, can cope with normal stresses of life, can work productively and contributes to the community. So a functioning human being that is healthy and well. That is mental health. You do need to know that definition almost word for word. It's very rare that I say that in psych, but with this one you really do. Your mental health can vary throughout your life, so there'll be times when your mental health is really suffering. Year 12 might be one of those. This doesn't necessarily mean you've got a mental illness, but there might be other times when your mental health is going extremely well. Perhaps you're working, studying, exercising, and everything is just fitting in extremely well. For me, a time when my mental health was extremely bad was when I had my knee reconstruction. I certainly struggled during that period of time. And so generally, we need to see it as something that's changing. We'll have times of highs and lows. Okay, compare that to a mental illness. So a mental illness is something that is actually diagnosed, and it's when something is starting to affect some of your functions. So if you read the definition, it affects one or more functions of the mind, and it starts to interfere with your thoughts, emotions, perceptions and behaviours. It's a serious departure from normal functioning, and usually the person or others around them are being caused stress and suffering. It tends to have a real impact on that person's life, and it's probably not so much temporary now, it's probably there for a longer period of time. And what we tend to find is it usually requires intervention of some sort of treatment. So if something continues for a long period of time and develops into a mental illness, this person will probably need some sort of treatment at some stage. Okay, so how do we decide what is normal and acceptable in our society and what is not? You probably find that you use these different approaches quite often in your life, but you just need to have an idea of them in terms of their actual names. So quite often when we're faced with a behaviour, we think about whether it impacts on the person's ability to carry out their normal daily functions in life. So if something, for instance, stops you from coming to school, and most students are expected to be here at school, then according to the functional approach, you might be considered to be abnormal because it's impacting on your ability to function in your life. We also look as to whether the appropriate behaviour for this day and age, for this day and age. So for instance, I would be considered abnormal quite a while ago because I was 34, single, not married and don't have any children. Whereas now, in today's day and age, that's probably acceptable and a little bit more normal. So we always need to look at the historical aspect of it. Medical approach, so is there a set of symptoms? For instance, if someone's extremely tall, we might say that they are medically abnormal because they might produce a lot of growth hormones and there could be some serious issues in terms of their body development that goes along with that. So there's an actual set of symptoms. Situational approach, it would be very inappropriate for me to rock up to work in my pyjamas on any given day. But if we had an army uniform day and there was a theme and everyone wore their pyjamas, that probably wouldn't be considered as abnormal. So we need to look at the situation in which the behaviour is being presented. Cultural, when I was in Egypt, I witnessed a funeral and they carried the coffin through the main street and had hundreds of people running after the coffin, wailing. Now I saw that as quite abnormal behaviour because culturally in Australia, we're very quiet at funerals. People sob very quietly. People try to stop crying, and they certainly don't run around the streets. So we need to look at the culture around the behaviour to decide whether something is acceptable or abnormal or normal. And the other one is statistical. So if something tends to be rare, quite often we label it as abnormal, just simply because we don't see it that often. You can find one behaviour and look at it from any of these perspectives, but you just need to have an understanding of each perspective. Okay, if you do have a mental health issue and you're wondering whether it is perhaps a mental illness, you might head off to see a doctor. And these are the steps that the doctor would take in terms of assessing where you stand. So, of course, they would conduct an interview with you. And this is usually a psychologist or a psychiatrist, but possibly even just your general GP. So an interview with you and have a chat to you about what's brought you there today. Step number 2, quite a few psychologists would usually give a whole heap of personality testing. So you'd have to do a whole heap of surveys to see what kind of personality traits you have and how strong those traits are. You would have to do a cognitive assessment, which is basically an IQ test to see if there's some low level of functioning or high levels of functioning that may also be contributing to the symptoms that you're having. Neuropsychological assessments, so these are things like MRIs, CAT scans, fMRIs, looking at your EEGs just to rule out any abnormalities, tumours, things like that that could be causing some of the abnormal behaviours that you're experiencing. Have to actually look at the symptoms. So this is part of the interview. You'll have a chat to someone about the basic idea of what's going on, but then you need to actually, as the doctor, go through and look at the clinical symptoms. And once you've got a list of symptoms, you can use 2 manuals, the Diagnostic Statistic Manual, or the ICD, which is the International Classification of Disorders and Diseases, to diagnose the illness. And we'll talk about those 2 manuals in a moment. From this, once you've made a diagnosis, you would then design an intervention. That doesn't come from these manuals. The doctor or counsellor you would need to see would design the intervention that they would see would fit. And it might be a counselling intervention. It might be a biological intervention, such as medication. There are a variety of interventions that could happen there. Number 8, of course, is try the intervention and treatment. And then once you've tried it, obviously you would need to get the patient in and review it and see how the treatment's going. So have another clinical interview and perhaps do some reassessments. And basically this cycle would continue until the person felt that they could be functioning quite normally in society. You do need to have a basic idea of these steps. Okay, so the DSM is basically a manual that psychologists and psychiatrists use to diagnose illnesses. It's a manual that's published by an American committee, published in America. It's up to its 5th edition. Well, it's about to be up to its 5th edition. I believe that it's in its 4th revised edition at the moment, but the 5th edition is due out this year. It's used to identify and classify symptoms, and it uses a multi-axial diagnostic system. So basically, people who use this book for diagnosis have to look at 5 different areas in a person before they can fully assess them. So, so basically, Axis 1 is any psychological disorders. So for instance, someone might be classified as having depression on Axis 1. Axis 2 would look at whether the person has any mental retardation, and that would come from the IQ test, but also any personality disorders that might go along with perhaps their Axis 1 diagnosis. So you might find that someone who's got depression might have a personality disorder as well, and be quite a pessimistic, narcissistic person. So they might get a second diagnosis on the Axis 2. Axis 3, the physician must look at any general medical conditions, diabetes, epilepsy, narcolepsy, anything, whether the person's got issue with their vision, any medical issues go here, because some medical issues unfortunately can influence some mental illness issues. So we need to have a look at the broad spectrum of what's going on. Axis 4, we also need to look at what's happening in the person's environment. Perhaps they're doing Year 12, perhaps their parents are recently divorced, perhaps they've recently become homeless. There could be numerous issues that's happening that could be impacting on the symptoms that they're having. So that's Axis 4. And Axis 5 is a global assessment of functioning where they're given a scale or a score from 0 to 100 about how well they're functioning in life at the moment. 100 means that that person is at an ideal level of functioning, and 0 means that they are dead. So most of us will fall between 1 and 99. Not many of us would get much past 90. You probably find that most of us function between about 60 and 80 most of the time, but we'll have a look at this in class. So patients will often have a diagnosis across a variety of axes, but this particular way of diagnosing does force clinicians to look at several aspects of the person's health and well-being, not just the symptoms that they're presenting with at that particular time. It doesn't describe, so this book itself doesn't describe causes of the illness or suggest treatments. So it will talk about, and we'll have a look in class, I'll show you the book, it does talk about perhaps when the illness might start being displayed, possible pathway of the illness, but it doesn't talk about what the best treatment is. But anyway, we'll talk about that in class. The ICD, the International Classification of Diseases/Disorders, this one's produced by the World Health Organization. So it has over 200 countries that input into this. And it's up to its 10th edition at the moment, with its 11th edition coming in the next 12 months or so. Basically the same idea, symptoms are identified, this book is used to diagnose those symptoms. The difference between this one is it's not just about mental illnesses, but physical illnesses are actually found in the ICD as well, whereas the DSM just looks at mental illnesses. So, what's good about diagnosing someone? Using either one of these manuals, there's some good things and there's some bad things. The good thing about getting a diagnosis is that if you walk into one doctor here in Australia with a set of symptoms and you get diagnosed as depressed, you should be able to walk into another doctor anywhere in the world with the same set of symptoms and get the same diagnosis. So these books basically ensure some consistency across the health professionals in the world. It also provides common language. So for instance, when someone says, I have depression, we tend to know some symptoms that are associated with that. So it's layperson common language, but also between doctors. You can say this patient suffers from depression and the doctor should know the key set of symptoms. Sometimes by diagnosing someone, it gives them a sense of relief. So getting that diagnosis like, finally I know what's wrong with me. And they might feel like they belong, to a group, so they might be able to get some support, maybe join an online forum for people who have depression. And this sometimes can be really reassuring for the people that have these illnesses. So there's some really good things about diagnosing people. That being said, there are some really bad things about diagnosing people as well. Bad things, first one, definitely stigma. So for instance, you get labelled or diagnosed with being depressed, and that is a label you now carry around with you. And if you tell other people, do they start to treat you differently? Do your work opportunities diminish? Do your friends diminish perhaps? So there's definitely a lot of stigma still associated with mental illness. The other thing is you get diagnosed and labelled with having something, but you never get undiagnosed. So you'll go to a doctor's and you'll get told that, yes, you've got depression, but then you go back and they don't ever say that you don't have depression anymore. So do you have depression forever if you get diagnosed once? So that's a bit of an issue. What is the point of giving a diagnosis? The other thing is that, two people with depression can have a very different set of symptoms. So just labelling them both as depressed really simplifies what can be quite a complex disorder. We just need to think about that. Does it mean that we lose some information about the person and the issues they're experiencing? Okay, so other criticisms of the DSM and the ICD in general, both of these are called categorical approaches, because basically we take a set of symptoms and we place people in categories according to these symptoms. So they either have something or they don't. So both the DSM and ICD have some issues. So the DSM, its biggest issue is that it's written by Americans. And this means it's definitely biased towards American culture, and that in itself has some issues. So there might be some things in the DSM that just aren't cross-culturally acceptable, very much about the American population. How do you decide what is a category in either the DSM or the ICD? For example, homosexuality used to be a category until 1973. Who decides what goes in these books, and what do we deem to be normal? The other thing is both of these symptoms require a patient to report their symptoms. So the patient goes off to the doctors and says, I feel these things. But of course we know that people report things that aren't always accurate. Sometimes they over-exaggerate, sometimes they don't report anything at all. So that can make them hard systems to use. The other thing is the American health system or insurance system is very much based on disorders that are in the DSM. So if something's not in the DSM, you might not get an insurance payout. That's often then a push to get things in the DSM. So that's an interesting societal issue. And then basically with the DSM and the ICD, you either have the disorder or you don't. There's no difference between two people. So like I was saying before, two people have depression, you just both have depression. You don't really know the difference between those two people and their sets of symptoms. So they can be very useful, but they definitely do minimise the information present about the person. Okay, so what is the other option if you're not using a categorical approach, the DSM or the ICD? The other option is a dimensional approach, and the new DSM-5 and the ICD-11 are both moving towards this dimensional approach. So dimensional rather than categorical. And basically a dimensional approach involves rating a person on the extent to which they show a disorder or symptoms of a disorder. So for instance, you might say that instead of them having depression, on a scale of 1 to 10, they have a depressed mood of level 9, whereas someone else might have a depressed mood of level 5. So it gives you an extent rating as opposed to either yes, they have a symptom or no, they don't. Kind of reduces stigma because it means that they're less likely to get labelled, not always, but perhaps people might start seeing things as a rating system and just symptoms as ratings as opposed to then summing up to a diagnosis. The other thing is that the patient often feels when they get rated on something that means they can change their rating. So if you've got a depressed mood of 10, which means you're severely depressed, but you might be able to go in a couple of weeks later and have that down to 5 or even a 3. So it gives them that idea that things can change and improvement is possible. Lots of detail then can be communicated between people, but of course the more detail that you communicate, that then adds in the issue of lack of consistency. So what looks like a 10 to one health professional might look like an 8 to another health professional. So it makes communication a lot more difficult, and hence why some people stick with the categorical approach. So both have their strengths and limitations. Okay, so that's it in terms of this PowerPoint. Like I said, there'll probably be one more to go for this area of study and for the year, but I hope you really enjoyed this topic.